Good morning, everybody. I'd like to present this topic on the state of cardiac transplantation in the year 2020. My overview is going to be talking about how we select candidates, listing strategies, indications, contraindications, outcomes, and post-operative care. The slide may or may not seem familiar to you, but the purpose of this slide is to remind the audience that the one-year mortality for patients with end-stage heart failure, typically known as class 4 heart failure, exceeds other diseases which we know have often fatal outcomes such as leukemia, lung cancer, and pancreatic cancer. I'm not going to go into detail over this graph showing the clinical course of heart failure. And if you focus on the right-hand side of the slide, you can see where my focus is going to be on with advanced therapies such as heart transplantation and mechanical circulatory support when patients actually have pump failure after many years of or many episodes of decompensation and slow but steady progression of a worsening status of heart failure. Heart transplantation remains the gold standard for the treatment of patients with advanced heart failure. And over the last 20 years, there has been a steady number of heart transplants done, varying between 2,300 to close to 3,000 cases in recent years. But overall, while heart transplantation is a wonderful therapeutic strategy, its overall application is limited in the Western countries because of the limited availability of donor hearts. However, in countries such as Asia, such as India, there's a huge opportunity for growth of this therapy for patients with heart transplantation, simply because it's been underutilized for a variety of reasons over the last several decades. We know that, compared to the lines in green, the transplanted patients have much better survival when you look at the various lines in greens over the different eras, showing the high mortality for patients dying on the heart transplant list. This one slide says it all, meaning the half-life, which tells you what the median survival is. The median survival is close to 11 years. And if you make it past the first 1 year, the half-life or the median survival increases to a staggering 13 years. This number may not look a lot, but when you compare it to the risk of dying within days, weeks, and months with advanced heart failure, 13 years of good survival is a wonderful outcome. And my approach to heart transplantation is going to be talking about indications, contraindications, and once you list patients, what's the best strategy in getting them to a heart transplantation. The classical indications for heart transplantation are listed here. Number 1, cardiogenic shock requiring either continuous intravenous inotropic support or mechanical circulatory support with an intra-aortic balloon pump, or other forms of mechanical circulatory support, including an LVAD or an impeller pump, for example. Excuse me. Number 2, persistent class 4 congestive heart failure symptoms that is refractory to maximal medical therapy. And the typical numbers for these patients are an ejection fraction less than 20%. But more important than ejection fraction is a peak VO2 less than 12 ml per kg per minute. Number 3, a less common indication, however, it's there, intractable or severe angina symptoms in patients with coronary artery disease that's not amenable to percutaneous or surgical revascularization. Number 4, intractable life-threatening arrhythmias that is unresponsive to medical therapy, catheter ablation, and or implantation of AICDs. Now, before we list patients, we want to make sure we're at the end of the rope, and I don't need to tell the medical audience this. Are there any reversible causes for heart failure, hypothyroidism, NSAIDs, other systemic illnesses? We want to make sure that these patients have been on maximal medical therapy. We all know that several weeks and months of maximal medical therapy can dramatically improve ejection fraction for these patients, lessen their degree of heart failure, and prevent them from going into advanced heart failure or reversing advanced heart failure for several months to years. Number 3, are they a candidate for biventricular pacing or what is known as cardiac resynchronization therapy. If they have ischemic heart disease, are they still candidates for coronary artery bypass grafting or stenting? And finally, if they have dilated cardiomyopathy with severe mitral regurgitation, are these candidates, though they are higher risk for surgery, are they candidates for mitral valve repair or replacement? Though I would like to remind the audience that in the last 5 to 8 years, the pendulum has shifted in favor of mitral valve replacement as opposed to mitral valve repair for patients with dilated cardiomyopathy, low ejection fraction with symptomatic severe mitral regurgitation. Now, are they cardiac limited? Patients with shortness of breath, wheelchair bound, wheelchair dependent could also have advanced COPD. So we want to make sure they're cardiac limited. Number one, the obvious is if they have cardiogenic shock requiring inotropes or an intra-aortic balloon pump. We do classic cardiopulmonary exercise testing, and I talked about this VO2 max, between 12 to 14 ml per kg per minute and an elevated VE by VCO2 slope. Every patient who's being worked up for heart transplantation or any other advanced heart failure therapy will have a right heart cath. We talked about this phenomenon often of ambulatory cardiogenic shock. Maybe a man or woman who's at home, advanced heart failure, able to walk, 100 feet, for example, but when you bring them in for evaluation, they may have a resting cardiac index, which is 1.6. And when you go by one of the classic definitions of cardiogenic shock, cardiac index less than 2.2, we call them, quote unquote, ambulatory cardiogenic shock. They're walking at home, but they're in shock. Again, as I said, most of these patients or everybody will have a low cardiac index with elevated filling pressures, maybe right or left-sided filling pressures, or often both. We want to look at their SVR and see, are they candidates for inotropes or just sometimes isolated vasodilatory therapy if they have a high SVR. And a lot of these patients have pulmonary hypertension, and I will talk repeatedly about the importance of objectively measuring and knowing what the pulmonary artery pressures are in these patients who are being evaluated for either LVADs or heart transplantation, and the huge impact PVR has on the outcomes of these patients. The absolute contraindication for heart transplantation, basically any systemic illness that confers a life expectancy less than 2 years, even if these patients were to have a normal heart or to get a heart transplantation. And I've listed 5, this is not an exhaustive list, but 5 examples. The most common are malignancies, and we talk about a cutoff of being malignancy free for 5 years. But in the recent years, with close working with the oncology service, there are some cancers, maybe for example, prostate cancer, that we may say they really don't have to be cancer free for 5 years in order to transplant them. I've highlighted fixed pulmonary hypertension because that truly is an absolute contraindication for heart transplantation. If you transplant a patient with PH systolic pressure greater than 60, transpulmonary gradient greater than 15, or PVR greater than 6, these patients are likely to die on the operating room table because that right ventricle will not work. This slide, again from the UNOS data, looking at thousands of patients, show the worst outcomes in patients with rising PVR. What are many relative contraindications for heart transplantation? Age greater than 70 is what most transplant groups do. An active infection, active peptic ulcer disease, severe diabetes with end organ damage, severe peripheral vascular disease that's not amenable to surgical or percutaneous therapy, morbid obesity or cachexia, and between the two, cachexia scares me more because of the even poorer outcomes in these patients. We often talk about cardiac cachexia. These are patients with advanced heart failure who can barely eat a few mouthfuls of their meal. And finally, renal failure, creatinine greater than 2.5. And when I say it's a relative contraindication, some of these patients may have to be worked up for a heart and a kidney transplant, which we not uncommonly do at the same time. Other relative contraindications, some degree of liver dysfunction, pulmonary dysfunction, recent pulmonary infarction from embolism, severe hypertension, irreversible neurological or neuromuscular disorder, active mental illness, or psychosocial instability because of the inability of these patients to be compliant with immunosuppression, um, various forms of drug, tobacco, alcohol abuse, and lastly, recent heparin-induced thrombocytopenia. And I just give this example how older age have worse outcomes, often because of the comorbidities in these older patients. The overall workup for heart transplantation, this is a summary slide, and I'll go through this exhaustive list. Serological testing for various viral infections, EBV, CMV, etc. Pulmonary function tests to make sure that they don't have COPD, colonoscopy to rule out GI malignancies, looking at their PRA, that will tell us if they're sensitized, for example, neuropsych assessment, social worker consult, cardiac surgery evaluation to assess their operative candidacy, CT chest and head, carotid ultrasound, lower extremity duplex, transplant teaching, again, more for compliance, making sure these patients can afford the operation and afford immunosuppressive therapy, vaccinations, and dental evaluation. How long do patients wait on the heart transplant list depends on their priority of the UNO status, their blood groups. For example, A, B, and B will wait a much shorter time than O group, body size and weight, and allosensitization. Now, what determines how long patients wait on the heart transplant list? The UNO status is now changed from a 1A, 1B, and a status 2 category to a little more complicated, but probably a little more fairer 1 to 7 category. Needless to say, 1A is a higher acuity than 1B, and 1B is a higher acuity than 2 who are usually at home. So the sicker you are, the more likely you're going to get a transplant. Blood groups, if you're an ABO, you're going to get a heart transplant much quicker than an O because there are many patients with an O on the list. Body size, height, and weight, if you fit in the average body size and weight, depending on which part of the world you're on, you're going to wait longer because there are more patients of that body habitus waiting on the list. And if you're sensitized, much like kidney transplants, etc., you're going to wait longer. Now, how does one get patients to a heart transplant? Most patients, if not everybody who gets a heart transplant, has been at some point in time on IV inotropes. Milrinone or dobutamine are the ones of choice. They are excellent modalities for short-term bridge to a heart transplantation, but these studies that were done more than 1 to 2 decades ago show that by 3 to 6 months, patients waiting at home on IV inotropes have a high mortality. Some of this data may be skewed because it was prior to the era of AICDs that would now prevent sudden death. So the survival with IV inotropes may be a little better than what is shown in these slides. Another uncommon way, but a way of getting patients to a heart transplantation is by ECMO. As you can see, in the last 15 years, the number of patients getting to a heart transplant with ECMO are in the low to mid single or double digit range nowadays in the 20s in the United States. And the reason is this: the survival with ECMO support is very poor, as low as about 50% at 6 months to 1 year. And the highest rate of mortality is in that first month of ECMO. What about other forms of temporary mechanical circulatory support, such as balloon pumps, percutaneous VADs? We see that over the last 15 years, the number of patients getting a heart transplant on a balloon pump or an impeller or one of these short-term devices is staggeringly increasing. And the good news is that the survival is also getting better, though the numbers are still small. A vast majority of patients in the United States get to a heart transplant through a left ventricular assist device. And I show this picture just to pretend what an LVAD is, even though this LVAD has not been in use for over 15 years. It was in use during my training in the late 1990s and 2000. It is called the HeartMate 1. You can see how big and bulky it is. But for those of you who are not familiar with an LVAD, even though this LVAD is no longer used, it has 4 properties that even the second and third generations of LVADs have. All LVADs have an inflow cannula that drains blood from the left ventricle. Number 2, there's a pump. Number 3, there's an outflow graft that pumps out blood into the aorta. And number 4, there's a drive line that comes out through the right upper quadrant that helps motor and provides the battery and brains of the pump. HeartMate 2, a smaller device used between the years 2005 and 2016. Again, no longer in use now because there's a new device called the HeartMate 3. Again, smaller, intrapericardial, works with a magnetically levitated pump, but again has all 3 things: inflow cannula, pump, outflow graft, and the drive line that's connected to the power in the brain. So HeartMate 1 to HeartMate 3, same prototype, just has got miniaturized with reduced side effects. Now, in this era, who gets an LVAD as a bridge to transplantation? I have not yet met a patient when I've offered him a heart transplant, or we've been talking about a heart transplant. They would always prefer a heart transplant straight off. Nobody wants to have an LVAD and then a heart transplant. But there are some groups of patients that do need a LVAD to prevent them from dying on the heart transplant list. And number 1 is the severity of the heart failure. If a patient is at risk in dying from in minutes to days to maybe less than a month and he's not going to get a heart, that patient needs an LVAD. Again, what is their estimated wait time for transplant? Are they a blood group O? Are they sensitized? Are their PRAs high? Is their body size not a great one to get a donor heart? If someone's going to wait over a year for a heart transplant, we may consider an LVAD. And most important, a relative contraindication that is reversible, such as pulmonary hypertension. Sometimes with an LVAD, the PA pressures come down over time and now translates into a patient that's now a candidate for a heart transplant. This slide is useful to look at because we see that in the year 2010, the number of LVADs overtook the number of heart transplant, and most of these patients who got an LVAD subsequently got a heart transplantation. Just to finish up on LVADs, we see that the number of patients who get a heart transplant via an LVAD has been increasing and is now in the 50% range. I'll just kind of highlight one paper that I've shown over the last 10 to 15 years, that patients who are at high risk of dying on the heart transplant list can be salvaged with an LVAD, and hence the rapid increase in the number of LVADs in the United States over the last 20 years. Just one patient scenario, 65-year-old male, non-ischemic cardiomyopathy with a LVEF of 25%, been on maximal medical therapy for 5 years, now has NYHA class 4 symptoms, 5 foot 10 inches, 100 kilos, blood type O, not a candidate for any cardiac resynchronization therapies, low blood pressure, slightly tachycardic, cool extremities. Peak VO2 is less than the classic 12 ml per kg per minute. Right heart cath shows normal right-sided pressures, severe pulmonary hypertension, elevated wedge pressure, low cardiac index, high PVR 7.8, slightly sensitized. This is a classic patient who's not going to get a heart transplant. And even if he did get one, is going to probably have a mortality excess of 50% because of the PVR, and should be bridged with an LVAD as a bridge to transplantation. So when do we like cardiologists and internal medicine folks to refer patients for advanced heart failure therapies? And this includes LVAD or heart transplantation. So this is a fairly exhaustive list. Frequent hospitalizations or emergency room visits for heart failure. The classic number that we all talk about is 2 within 12 months. Intolerance to neurohormonal therapy due to hypertension. Patients who have had their beta blocker, ACE inhibitors being reduced during their outpatient visits. Worsening renal function. Inability to walk 1 block due to dyspnea or fatigue. This is a question I always ask patients in clinic when I'm evaluating their candidacy. Can you walk a block? And if they say yes, I'm kind of hesitant to offer a major therapy to them. RV systolic pressure greater than 50, frequent ventricular arrhythmias, patients who have worsening lower extremity edema from heart failure, and you know this, their Lasix is 20 BID, 40 BID, 80 BID, and that's not working. Low sodium, patients who are non-responders to CRT, which is the BiV therapy, the need for inotropes during a hospitalization, and few years ago, there's a Seattle heart failure predicted 1-year survival less than 90%. Now, I just want to highlight that all these things that I've listed, there are papers, and I haven't quoted them here, that show for many of these patients have a mortality between 25 to 50% at 1 year, which is why these have become classic indications to refer patients for advanced heart failure. And I just kind of flash the screen again. Now, when I was in college, I used to play a lot of basketball here, and you can see, Thambu's on the corner here, and my other close friend Thomas Palakuran is here. I still hope it's a pastime for all the men and women in CMC. So moving on to the final 20 minutes of my talk, now we talked about indications, contraindications, how to get a person to a heart transplant, and now the time has come. Patients on the list. How do we proceed? How do we take care of the patient, and what happens? So in the next 20 minutes, I'm just going to talk about donor evaluation, post-operative care, immunosuppression, and just a couple of major complications. Classic donor selection criteria, age less than 55 years, and this is most important, absence of any significant structural abnormalities. No LVH, and our cutoff is wall thickness, either the septum or the posterior wall, less than 14 millimeters, no valvular dysfunction, even mild to moderate mitral regurgitation, for example, is a no-no, though there have been some anecdotal cases of fixing the mitral valve at the time of transplant. No congenital cardiac abnormalities other than a patent foramen ovale, and no significant coronary artery disease. 20 to 30% lesions are okay, but anything in excess of 40, 50% is a no. Once a donor team has gone out to look at the heart, basic stuff like LV function should be more than 45%, ideally should be more than 50%. Achievement of target hemodynamics after hormonal resuscitation and hemodynamic management. If the patient has a right heart cath, you want these, adequate hemodynamics, negative serology, and no active malignancy or serious infection such as meningitis in the donor. There are standardized algorithms when we go to procure a donor heart. Most of these donors have been resuscitated hemodynamically with insulin, steroids, triiodothyronine, vasopressin, especially in the patients with EF less than 45%. It is not uncommon at all for a patient, for example, with a subarachnoid bleed or a motor vehicle accident, for the first echo after brain death to have an EF of 20%. But if you repeat the echo, which is almost always done in 24 hours, that EF is up to 45% and 60%, especially in young donors. Currently, most donor hearts are harvested by a transplant donor team from the transplant recipient center and then brought back for implantation. And a cold ischemic time of 4 to 5 hours is generally considered safe. Can be pushed to greater than 5 hours, especially in pediatric donors. And for cold ischemic time, that refers to from the time a clamp is put on the donor heart and the heart is removed to the time the heart is sewn back and the cross clamp on the recipient is removed and warm blood perfuses back into the donor heart. That's called the cold ischemic time. There are two techniques for cardiac transplantation, and I do have only one slide on this. I know the technique that most people do is a bicaval technique. It consists of 5 anastomosis, aorta to aorta, pulmonary artery to pulmonary artery. You can't see the left atrium anastomosis because it's at the back of the heart. Superior vena cava to superior vena cava, and IVC to IVC. So that's the bicaval technique. The technique that is no longer used is the biatrial technique. That's RA to RA, LA to LA, and aorta to aorta, and pulmonary artery to pulmonary artery. The bicaval technique is more physiological, preserves SA node function, less risk of postoperative arrhythmias, and the need for pacemaker after heart transplantation. I'm going to kind of just mention these drips. If you ask 20 different centers, each one will have their different flavor of cocktails for postoperative drips. For us, we often use a combination of epinephrine and isopril. And in case these patients have some degree of pulmonary hypertension, some aggressive pulmonary vasodilator therapy like nitric oxide or Flolan is recommended, but our bread and butter is epinephrine and isopril. All patients will get an intraop TE, Swan-Ganz, close monitoring of electrolytes and lactic acid. Post-op, the same. I keep saying lactic acid because it is not uncommon for these patients after they get to the ICU to kind of have a reperfusion injury. And all we see is patients' lactic acid going up, 5, 10, I don't know the units, but it kind of goes up a lot. Bicarb is low. And I know the intensivists always say never treat metabolic acidosis with sodium bicarbonate. But the one thing I always do, and I know all of you probably are going to be laughing at me, is I treat these patients who are metabolic acidotic after a heart transplantation. I give them bicarb. And just from my own experience, I find that the pressors that all patients after a heart transplant or any major cardiac surgery are on, if it's a homograft or something for endocarditis, when they are metabolically acidotic, the pressors don't work and you have to escalate pressors. So I kind of give a couple of amps of bicarb before the intensivists find me. And usually the pressors work then. So that's all I'm going to talk to you about ICU care here. So, or at least on acidosis. So we talked about allowing during surgery, once the heart is sewn in, we usually allow an hour for blood to kind of perfuse of the heart to kind of let the heart wake up and beat. Again, I talked about various combination of drips, pulmonary vasodilator therapy, and it's important to pace these hearts with atrial and ventricular pacing. Post-op, we talked about that reperfusion injury. So I always recommend, again, this is nothing objective here, but slow weaning of pressors and inotropes. Pay close attention to whatever invasive monitoring you do, and close attention to urine output. In a patient 6 hours after heart transplant, if the CVP is 19 or 20, that's not going to be good for the right heart. So we aggressively get the renal service involved and do not hemodialysis, but a CRRT to get rid of excess volume. So clearly a major teamwork in that first 2-3 days after a heart transplantation. Standard antibiotic prophylaxis, Bactrim, CMV, things like that, antifungal therapy. I'll spend a minute or two on post-op immunosuppression. For those of you who are familiar with other solid organ transplantation like kidney transplants, nothing different. Everybody will get, Solumedrol 1 gram before going to surgery and MMF in pre-op. We always give 500 of methylprednisolone, 500 at the time the cross clamp is released. They may do this for kidneys also. Post-op MMF and steroids. One of the things that we have been doing aggressively in the last few years is Simulect, which is Besimumab, and patients who have elevated creatinine who we expect a further bump in their creatinine and worsening renal function, and we can't give them the other drugs. This one protects them for several days in these patients. In addition to immunosuppression and antibiotics, these patients get a bunch of other medications: aspirin, lipid therapy, calcium carbonate, antihypertensives is important, and hydrazine and sometimes sildenafil if they have elevated pulmonary artery pressures. Rejection, again, this all of you know from the kidney stuff. There's cellular, humoral, and acute versus chronic. Treatment modalities, again, our cardiologists deal with all this, so I'm just kind of repeating what I've got from them. Acute cellular with without hemodynamic compromise, Solumedrol pulse. With hemodynamic compromise, you add thymoglobulin. And for AMR, plasmapheresis, IVIG, rituximab. Antibody-mediated rejection, there's a long list of things we can do, but what we usually do is plasmapheresis. and rituximab are the two modalities that are commonly used. Couple of complications, and the most important that I worry about is right ventricular dysfunction after a heart transplant. What are the risk factors? Number one, pulmonary hypertension, PVR greater than 4, undersized donors with a greater than 25% mismatch with recipient size, older donors, and risk factors for excessive bleeding after the heart transplant. Why is that a risk factor? When you give them a lot of blood products, that usually stuns the right ventricle. So these are the various risk factors for RV dysfunction. How do you treat RV dysfunction? Use of aggressive pulmonary vasodilatory therapy such as nitric oxide or Flolan, and a couple of surgical techniques such as leaving the chest open and putting a temporary right-sided device. This is a picture of a patient with an open chest. You can see we put that S-mark dressing to allow the RV to expand and not kind of choke on the right ventricle. So this patient will have an open chest for a few days. Primary graft dysfunction is when the heart does not work after the clamp is released and you've allowed adequate reperfusion time. It's kind of something that makes one's heart just sink to even talk about this. There are various forms of primary graft dysfunction. Could be right side, left and right side, or heart failure with failure to oxygenate, which is very rare. How do you treat right primary graft dysfunction? Mechanical circulatory support. And I have a couple of cartoons to show you all, either direct supporting the right and left side with some temporary devices or putting the patient on ECMO. For those of you who are not familiar with ECMO, this is a cartoon showing central ECMO. Basically, it's taking deoxygenated blood from the right atrium with a cannula, sending it to a pump that oxygenates it. It's typically a roller pump and pumps blood back between 3 to 5 liters a minute back into the ascending aorta, completely bypassing the heart and the lungs. What does it do? It rests the heart for a period of 1, 3, 5 days till pulsatility returns. Studies have shown that aggressive early use of ECMO can save these patients, but if you get to the ICU on high-dose pressors, acidotic, and saying, let's hope things get better, that is associated with much higher mortality than an aggressive use of ECMO. This cartoon again shows, rather than ECMO, which has an oxygenator, you can directly support either the right side of the heart. Excuse me. For example, I'll just mention just the right side. You drain blood out from the right atrium. Again, it goes to a pump, and that blood pumps back into the pulmonary artery. You're just bypassing the right ventricle. If you wanted to do the LV, for example, you drain blood from the left atrium. I know the left atrium is not on this side. This is the left atrial appendage, but this is a cannula that's placed in the right superior pulmonary vein that drains blood out from the left side, again goes out into a pump, and the blood is pumped back into the ascending aorta. So just a cartoon showing that you can separately support the right side or the left side, or do both, all without an oxygenator. Renal dysfunction, again, is common after heart transplantation, may affect what kind of immunosuppressive therapy we do. And the renal team is essential for helping with this because there's a high need for CVVH. In closing, I show these pictures in the late 1960s and the early 1970s. After the first heart transplantation was done, we just hit the 50-year mark last year by Christian Bernard, who did in 1968. Several hundred of these transplants, died within several weeks. And Life magazine had this article, asking for a moratorium on heart transplantation. Certainly, this is a therapy that has come a long way. And I think, hearing about that there is an increasing potential for this to grow in India. There are some limitations of heart transplantation. As I showed you in many slides, even though it's a dramatic therapy, the numbers are limited by donor availability. There are stringent criteria for eligibility. There is a risk of progression or death while patients are waiting for an adequate heart. Immunosuppression is not easy for some patients, and there is no hope of myocardial recovery. There are some alternatives to heart transplantation, like the LVAD as shown in this cartoon. And finally, will LVADs be the future? I personally don't think so. The dramatic and the long-term survival of heart transplantation will make it a value therapy for the next so many years. But this slide just shows that with the latest HeartMate 3, at least at the 2-year mark, the survival of 82% is kind of on parallel with heart transplant. What we don't know is what that trajectory of survival with an LVAD, even with the later generation, is going to be at the 3, 5, or even at the 10-year mark. So in conclusion, you need careful recipient selection. And again, I stress on how not to underestimate pulmonary vascular resistance. Careful coordination to favorably influence the timing of the donor procurement is very important, because you don't want to have the donor heart arriving in the operating room and you haven't opened the chest yet. Meticulous pre-op recipient management, make sure the patient is off Coumadin, etc. And pulmonary vasodilatory therapy is critical. Meticulous conduct of the transplant operation, and one should have strategies to manage graft dysfunction. If the heart doesn't pump, you need to be able to support it. I'll just end with this saying from C. Walton Lillihei, who's one of the pioneers of open heart surgery: good judgment comes from experience, and experience comes from bad judgment. Thank you.
Thank you very much, Ranjit. It was an excellent talk. Now we have time for questions. Are there any members who are present here who would like to ask any questions? If there are none, I'll start off with one. Ranjit, could you explain a little bit more about ambulatory cardiogenic shock? You said that is one of the softer indications for cardiac transplant. It's something novel for us.
Yeah, so again, cardiologists are the ones who mostly deal with it, but I see this on a weekly basis. They bring in a patient from clinic with shortness of breath. He's probably class 4, but has never been admitted. To a hospital. He says he can walk, half a mile. He struggles to walk up a flight of stairs, but he's been doing okay for the last 2-3 years. He's on reasonable medical therapy. And he's been referred to the cardiology team to work up for a heart transplant. So almost all these patients will get a right heart cath. And then the right heart cath shows an index of 1.5 or 1.6. Clearly, that's cardiogenic shock. His blood pressure has been, 90/70. And, normally if you saw someone with a cardiac index of 1.6, 1.7, that's one of your many indications for shock. That patient would need to be admitted. But when you tell this patient, hey, we need to admit you to work you up, he says, I've been fine, I've been doing this, why all this rush? And this phrase of ambulatory cardiogenic shock, came out many years ago, and the dilemma is what to do with this patient. Certainly you don't want to rush and, do a heart transplant on him tonight, but he's stable, he's got low blood pressure, he clearly has class 4 heart failure, and he's got cardiogenic shock from your classic definition of, one of the many definitions of shock is cardiac index less than 2.2, correct? So, and he's 1.6, he's walking at home, he's never seen the inside of a hospital bed. So, what do you do with these patients? What we have been doing is, we're not rushing to put an LVAD on them or a heart transplant. Many of these patients, we may optimize their medical treatment, but many of them may come into the hospital and be tested with inotropes. Maybe once they see some milrinone, they're going to feel better. They say, doc, I never felt this good in the last 1 year. It's happened so slowly that they just gotten used to it. So that's kind of what we've been doing. And if they get better with milrinone, now we can't leave them on milrinone forever. So that kind of leads them to, is this a patient for a heart transplant? Then they get their, peak VO2 and these other tests that may push them into one category or another.
Okay. Anybody else would like to ask any questions? One more question. Most people can't afford cardiac transplant because of the costs in India. Would you think this new LV assist device, the HeartMate 3, would that be financially more an attractive thing, at least give them a couple of years of good quality life?
I actually think, Kambu, that, the cost for a heart transplant, if you ask me, should not be any more than a coronary bypass or a valve replacement. The big cost is the donor. So, that's a huge cost of sending out someone, 2 hours away and getting, but the actual operation is not more expensive because you're not using any artificial valves or anything like that. And the post-op cost shouldn't be any different from any other cardiac surgery. And the long-term cost should not be any different from kidney transplantation. So I actually think, Thambu, that cardiac transplantation is a very, very viable option, especially for people who cannot afford the high prices, because you're not really, it's mostly getting the donor heart and paying for all that. But once the patient is in the hospital and has the operation, you're using the same heart-lung machine that you use for a coronary bypass or a valve replacement or an aneurysm. You're not using anything prosthetic. There are 5 anastomosis that, that can be done with 5 sutures. The rest of the operation is like a routine heart surgery. The post-op care may be a little more complicated, but maybe like doing a aortic valve replacement on a low EF patient for, so these patients are a little sicker. And long-term immunosuppressive is no different than the thousands and thousands of patients who undergo kidney transplant in India. So I actually think the cost should not be prohibitive.
Probably one last question. Are there any new drugs coming up for heart failure, like the amlenone, milrinone, or the ARNIs? Are they like postponing the need for heart transplant, or they're just a myth? What is your feeling about those?
Do you have experience with Entresto or?
No, we're not using them, much of them.
I mean, I don't think it's a myth. I do think, good heart failure medical therapy, even in the patient with class 4 heart failure, can keep the patient off the list, off a hospital bed for several months and even sometimes a year or 2. We've had patients who, because of their body size, and sensitization, we're not able to get a heart transplant. We actually just had a patient who's been on the list for 8 years. She finally turned 71 and we took her off the list. Now, either we listed her too soon or it was good medical management for many years. So I do think there is a role for aggressive and thorough medical treatment, going from your beta blockers to Lasix to other stuff, but I think their medical treatment of heart failure is imperative.
Okay. I don't think there are any questions online either. Thank you very, very much, Ranjit, for your time. We really appreciated your talk and enjoyed it a lot. Probably there'll be some questions. I'll mail you if there are any later on. Just so nice to see you.
Give me my slides if you need to share it with the postgraduate.
Surely, if you can, we'll appreciate that. Thank you so much, Ranjit.
Yeah.
Have a good day. Okay. Bye. Bye.